Hey everybody, it's Ryan. Hey, today we're going to talk about heart failure and the community paramedicine interventions associated with that. Population of interest for me was congestive heart failure patients in northeastern Pennsylvania with the goal of prevention of readmission of 30 and 90-day readmission rates, and investigating how mobile integrated healthcare, which is synonymous with community paramedicine, essentially EMS providers who are paramedics or pre-hospital registered nurses, which is something in Pennsylvania that allows a registered nurse to operate as a paramedic, as well as a nurse, can intervene with these patients in non-emergency settings in their homes in the community. With the prevalence of heart failure, about 5.7 million Americans have heart failure, estimated to cost the U.S. about $30 billion collectively annually, with about a 46% increase in the prevalence estimated by 2030. Medication compliance remains a population-centric issue of concern. AHA study in 2016 is finding that medication adherence to interventions actually decrease readmission. So as long as they're adhering to their treatment pathway, they're adhering to their medication regimen, they decrease readmission. Possible solution could be to assist with the medication compliance for these complex patients through the use of mobile integrated health. Implementations of the APHN subroles, focusing on the efficacy of these programs through reducing 30-day readmission rates and improving morbidity and mortality. As a researcher, as a clinician, preventive care promotion, assisting with community-based interventions with mobile integrated healthcare and community paramedicine, and furthering those Healthy People 2020 goals through oversight and community support of clinical prevention services. As an educator, patient education of the EMS providers to help them expand their skill set and their knowledge, as well as community and public health education. As a collaborator and consultant, focus on that role as a nurse navigator, bridging the gap between the various inpatient, outpatient, community models and providers and services that are out there that are helping these patients. Sometimes it's a sea to navigate alone. And then from an advocacy perspective, promote legislation to support funding, support some scope of practice adjustments needed for utilization of these mobile integrated healthcare providers. Intervention strategies, like we talked about before, kind of research some of these questions, look at what the efficacy and the fiscal and clinical feasibility is for paramedics and pre-hospital registered nurses to intervene with this patient population. As a clinician, implement evidence-based practice and interventions, clinically support the entire collaborative MIH team, and develop care plans for the team to assist with execution of interventions. As an educator, patient education, clinician education, like we talked about. As a collaborator, creating that synergy as a nurse navigator, and as an advocate, like we said, advocate for some of those funding of key programs. Review literature showed not a ton of information associated with mobile integrated healthcare. However, there was a great program in Texas, Mobile MedStar Health, or MedStar Mobile Health, from 2010 to 2015 that showed a reduction in 30-day readmission rates among CHF patients, as well as charge avoidance of about up to $30,000 or so per patient that was admitted. So definitely the program showed some potential efficacy for future expansion. A targeted review of all peer-reviewed journals in 2019 showed a real small number really having significant data proving MIH, community paramedicine intervention. The rest of them really didn't kind of meet the criteria, and really what it showed is that there's just a need for some additional research. However, what research was done was positive for the use of clinical pathways, as well as a great aggressive patient care and follow-up. Meta-analysis found that positive living environment correlates with positive outcomes. So if they have a supportive living environment, they have a supportive family structure, they have support in the community, they're going to have more positive outcomes, especially with HF. Educational offerings for patients were found to be short duration activities. They lacked depth, they lacked follow-up. So that was a key area that was identified in this 2013 study that we actually looked at for education and how we can kind of better streamline that for the patient. And as always, there's a link between the patient's environment as well as their outcome. Use of clinical pathways to prevent readmission was an article we reviewed, essentially showing that patients over the course of a year that had heart failure in two different clinical units, when matched together, or when kind of compared together rather, those that had a clinical pathway they followed for acutely decompensated heart failure tend to have a decrease in readmission versus those who did not. So again, some evidence just showing that clinical pathways can potentially reduce readmission. We talked about MedStar Mobile Health. Like we said, resulted in a 30-day decrease in readmission rates, high patient satisfaction, significant charge avoidance. So definitely kind of laid some groundwork for the possible positive efficacy of interventions by EMS providers in the field during non-urgent situations. And that large meta-analysis we talked about, really suggested a decrease in acute care utilization for anyone involved in MIHCP, but it was could not find a large randomized controlled study in a peer-reviewed journal. Therefore, its primary suggestion was to somehow provide some in-depth research in order to really prove the efficacy of mobile integrated healthcare. Prevention efforts for the HF community really focus on tertiary prevention level, preventing the disease from getting worse. Single interventions were found not to be effective in reducing readmission, but instead multifaceted interventions focused on partnering various levels of providers were found to have the best impact. As a collaborator, the APHN can seek to kind of bring this multidisciplinary team together because outpatient physicians, inpatient physicians, community health, community paramedicine, telemedicine, all these different care teams, when acting kind of synergistically, acting together, working with one kind of common goal, one common kind of set and pathway, can potentially have a significant outcome for the patient that really impacts their care positively. And then, the APHN can provide knowledge to kind of ensure that this collaboration occurs. You get the right resource to the right patient at the right time. Situation-specific theory we focused on was the naturalistic decision-making theory. Basically said that patients make care of these decisions based on a lot of factors in their life, based on their knowledge, based on their experience, not based on logic from our perspective. So there's a lot of different things that can can create factors for why patients may or may not be compliant with their treatment pathways, with their medication regimen. So we need to take all of that into account when we look at providing a plan and a care plan for these patients. Additionally, they must be able to maintain their health through symptom recognition, which is pretty key. Like we said, for risk factor identification, it's still tertiary level because these patients already have the disease. And our focus is really going to try to be some sort of readmission reduction. Educational interventional priority, looking back at that self-care theory, it's patients' knowledge of their disease process, their symptoms, and what's critical versus what may be kind of their new norm, so to speak. Promotion of patient self-care, increasing their knowledge, improving their ability to recognize a dangerous symptom versus what might be now a new symptom that's kind of a new baseline for them. Needs-based education plan focuses on recognition of dangerous symptoms, development of some sort of common educational tool for them to utilize, things that the inpatient provider, the community paramedicine provider, et cetera, can all feed them this information to hopefully kind of hear it from multiple sources and potentially have a good outcome and really kind of comprehend some of this information. Additionally, we talked a little bit about team approach to electronic medical records and having all these different teams out there, the mobile integrated health team, the inpatient team, the outpatient team, all be able to see each other's records and see each other's charting. What do we use for this? The heart failure zone tool is what we educated the community paramedics on. It's about a 9th to 10th grade reading level. It's one page. It's easy to read and it's color coded. This is the tool. Basically, its goal is to be able to tell the patients, hey, now you have CHF. Here's kind of what your new baseline is in this green area. If this is what you're experiencing, this is normal. If it's in this yellow zone, you should call your doctor. If it's in this red zone, you should call 911. And the goal is to really have the patient understand their new symptoms, understand their new disease, and be able to act accordingly based on that education. Our plan was to have the MIH providers provide the education to the patients, as well as have the physicians on the inpatient side provide it before discharge, so they hear it from multiple different teams. And we did some education directly to the MIH providers so that they could provide the kind of train-the-trainer education in the field and have the patients learn how to utilize this tool. The community we worked through was Lehigh Valley Metropolitan Statistical Area. It's kind of a 3-city MSA in eastern Pennsylvania. The total population of the area exceeded about 800,000 in 2018. For geographic purposes, it's about an hour north of Philadelphia and about an hour to an hour and a half west of New York City. English and Spanish are the predominant languages in the area. Industry and economy. Currently, finance, real estate, healthcare, manufacturing, warehouse, and medical device manufacturing are the key business and industries. Bethlehem Steel Corporation was the primary economic driver from the late 1800s until about 1990, 1995. And now, after the decline of that corporation, this redevelopment with multifaceted disciplines occurred, and our current GDP is estimated about $40 billion, which is, interestingly enough, more than Vermont, Wyoming, and about 112 different countries across the world. No significant health events that we found. The only thing that was noted was transiency due to the kind of quick geographic access to New York and Philadelphia as a potential cause of health disparity. Local government structure. Lehigh County is one of 67 counties in Pennsylvania. Each county is different based on our size and structure because Pennsylvania is a commonwealth, so we do things a little funny sometimes. Home rule charter basically just means that we have an elected branch, like an executive, so we have a county executive as well as a legislative branch, kind of similar to a president and Congress type of setup. Independent municipalities exist within the counties, so it's not just one county-wide municipality, but rather 30 some odd municipalities within the county that then kind of report up through the county and then up to the state. There is no county-wide health department. Key community leaders we identified: Vicki Kistler from Allentown Health Bureau, Kristen from Bethlehem, some large municipal EMS leadership involved in the program, Tom from Bethlehem City Paramedics and Eric Gratz, the EMS chief from Allentown City Paramedics, and two primary health systems, Lehigh Valley Health Network and St. Luke's University Health Network. We work with Lehigh Valley for our project, who's currently working on some beta testing for feasibility studies related to MIH. Congress and state representation pretty much split between Republicans and Democrats in an interesting turn. It's a kind of middle of the road MSA area. Health policy, we didn't really find much specific to the HF populations from APHA. We did find a little bit related to community health workers related to palliative care, but nothing further. AHA did have a policy related to formal support of community health care workers in a goal or an effort to reduce morbidity and mortality. Conceptually, this kind of links up to the MIH program. Nursing Code of Ethics and Advocacy, again, kind of advocacy's role correlates to Provision 2, nurses' primary commitments to the patient, whether it's an individual, group, family, or population, so we should advocate in order to support them. The kind of demographics, you're looking at about 88% of the population over the age of 25 has a high school diploma, 29% have bachelor's degrees, median household income is about $60,000, and unemployment's around 3.8%. Looking at chronic diseases, heart disease is kind of number 3 for the county, the state, and the nation. It is number 2 for leading cause of death and number 1 in the state, as well as nationwide. Communicable diseases, birth statistics, again, kind of on the edge there. And crime is both below the rates of the state. Data analysis, we talked about mortality for everything other than strokes is at that nationwide and state averages kind of below there. Clearly note that heart disease is prevalent in the area and is one of the top 5 leading causes of death. Windshield survey showed a rapidly growing urban, suburban, and rural communities. Healthy communities managed through both of those nonprofits that we talked about. Health ranking data, really the availability of mental health providers didn't necessarily meet the demand of the patients in the community. Otherwise, the ratio of primary care physicians to patient is kind of falling below national benchmark and statewide averages, so something to keep an eye on. Obesity is higher than or equal to national statewide average. Otherwise, nothing directly relates to CHF patients. There's a street medicine program, as well as prevalence of well-advertised children's resources and free clinics and healthcare support in the area. Talked to 2 key informants, EMS Chief in Allentown and Police Sergeant in Salisbury Township. Specifically related to this, they talked about lack of opportunity for physical exercise, transportation difficulties for low socioeconomic residents, reliance on 911 and the EMS system for all patients, basically. Informant 2 sees EMS, has seen the consequences of poor health, specifically saying that, the residents in lower socioeconomic areas tend to withhold seeking care. They're using 911 kind of as the call them all for everything. They abuse the 911 system. And a lot of this relates to a lot of patients going to the ED that might not need to be there, which includes sometimes our CHF patients. Like informant number 1 said, the patients are often supportive and trusting of local EMS, and patients with HF are also usually very well known by local EMS. Informant number 2 talked a little bit about the unique perception EMS providers have by going to their homes. And we'll get into that a little bit in the second part.